So my name's Renee. I'm a physical therapist. So today we're just going to talk about the knee. So I had spoken to Shula about different things that might be of interest. So I plan on coming in once in a while. If there's anything that you guys are interested in certain topics, you could always bring it up to my attention or their attention, because we really want to do this to be informative for you guys, just to make it as informative as possible. So there's different things we're going to discuss today. We're going to talk about knee anatomy and the muscles. We're going to talk about different complaints of pain, so different things that you might notice that are painful or in different areas, and we'll try to identify what could be possible causes. A physical therapy examination, so basically what I do when someone comes into my office and says that they have knee pain. Common impairments that you might find in older adults, and then we'll also do some exercises to talk about how to rehab the knee. So just some information on what I do. I treat adults in outpatient setting in a physical therapy office. I specialize in treating adults with neurological disorders. So I mostly see a lot of patients that have MS or Parkinson's, brain tumors, stroke, things like that. But I do also see a lot of patients coming in for orthopedic problems, like back pain, shoulder pain, knee pain, sprains, strains, things like that. And I also work with kids in a school-based setting. So I do a little bit of everything. Oh, have you guys ever experienced knee pain?
Yep.
Yes.
Yep.
Yeah, I think that everyone to a certain extent. You want to come stay over here?
Yes.
So I think that everyone, to some extent, has experienced some form of knee pain. I know I've had a lot of knee pain, and I'll talk a little bit about that, just my experience with it. But it's something that I think everyone has experienced, or at least knows someone who has experienced it. So before we get started, I want to just talk about the anatomy, because we're going to be referring to a lot of it. I'm going to be saying a lot of those words throughout the presentation, so I just want to get you guys familiar. So this is a picture of the bones in your leg. So there's two very big bones that you see. So the first one is called the femur. So it's the bone that starts up from here and it goes down to your knee. And then the bone on the bottom is called the tibia, and that's the bone that goes down your leg on the bottom. So where the femur and the tibia meet, that is your knee joint. So it's basically a connection of those two bones, and that's right over here. Right up in here. And then in the middle over here is the patella. It's a little circle, and that's also known as your kneecap. So those are the major bones that we want to talk about today. Okay. So where the two bones meet, there's two actual joints within the knee joint. There's a patellofemoral joint, which is where the kneecap and that big bone on the top meet. So that's this joint over here. And then there's the tibiofemoral, which is the connection of this bone and that bone. So there's actually two joints within the knee joint. So when someone has knee joint pain, it could be in either one of those joints within the knee. And if you guys could see, the way that the knee is, the way that the two bones meet, they're not so comfortable together. They don't fit nicely like a puzzle piece. They're kind of incongruous, which means that the surfaces are very bumpy and they don't fit so nicely together. And that's why, because of that shaping that they have, there's so many structures in there that try to keep it together and like nice and cushiony. But that also means that a lot can go wrong. And that's why there's a lot of injuries that are associated with the knee. It's actually the most commonly injured joint in the body. Alright, so the first muscle that we're going to review is called the quadriceps muscle. Are you guys familiar with the quads? So this big muscle group right here on the front of your leg. It's a very big, meaty muscle. And it's made up of 4 muscle groups that come together to make this one big muscle. So if you see in the picture here, there's 3 strands that you can see, 1, 2, 3, and then under this one, there's a 4th one. So they all come together like ropes to meet together this one muscle, and its main job. You want to ask a question?
I want to ask you,
Yeah.
what do you call the muscle
that goes down the front of
The sciatica.
So in the front of the knee, right here in the front, there is no muscle. This is just bone. So there's a muscle up here, and there's a muscle down here, but no bones, no muscles in the front.
Well, when I was a kid, I'm walking in the street, the kid is playing football. His inertia pulled him over to me while I was standing, and he fell against my knee. And it felt like something was misplaced in the front of my knee, and I've had trouble with it ever since.
Wow.
So it's possible that it was your kneecap, which is that bone in the front. But we're also going to review some ligaments that pass on the sides, on the front, and the back of the knee. It could have been one of those. Not necessarily a muscle, but definitely a structure could have been misplaced that might have been causing that type of pain ever since.
Is it ever possible to replace it, put it back where it belongs?
Well, I don't know exactly what it is, but it's definitely possible to do exercise and rehab to help with the pain, that's for sure. Definitely. So this muscle, its main job is to make your knee straight. So just me standing up right here, this muscle is activated because it has to keep my knees straight so I can stand up. So just imagine standing up, walking, running, that muscle needs to be on at all times. So it really needs to be working to its full potential. So much can go wrong with this muscle, and that's why we're really going to spend a long time talking about it today and reviewing exercises of how to strengthen that muscle. Everyone in this room definitely has some weakness in that muscle. I know I do.
You're going to have surgery, knee surgery replacement.
Knee replacement surgery?
Yeah, next week.
Okay, so you better make sure that you get therapy when you're done. It's
For what?
really
What did she
important.
have?
She's going to have surgery.
Say it again?
Oh, she's going to have surgery on her knee,
Yeah.
that's why.
Yeah. Knee surgery next week.
Oh, yeah. Like a replacement?
Yes.
Yeah.
So one portion of the quads that I wanted to show you guys is called the VMO. So if you see in the picture here, the arrow's pointing right to where that muscle is. It's part of the quads, but it's right at the tip, right where my kneecap is. That muscle is super important for stabilizing the kneecap. So a lot of times a patient will come in, I'll test their quad strength, and they have pretty good strength, but then when I go and test that little part of the muscle, I want to see if it's turning on, it's not even activating. And if that muscle is not activating, it's not controlling the kneecap and it's not able to stabilize. It's a really tiny muscle, but it's so important, and especially after knee replacement surgery, I do tons of retraining and strengthening of that muscle. It's a really important stabilizer of the knee. So the next muscle we're going to talk about are the hamstrings. It's also a really big group of muscles, but that runs in the back of the leg, right here. And it's also made up of 3 big muscle strands that come together to form the muscle. And this muscle's job is to bend your knee, like this.
So you just bend it backwards.
Just like this. It helps you flex the knee. So if I say flexion, it's this motion, bending the knee, and extending is making it straight. I might go back and forth between those terms. Okay, and then another muscle is the gastrocs, which is also known as the calf muscles. So they run in the back of the lower part of your leg. It's really a lower leg muscle, not really a knee muscle. But when we try to bend our knee like this in open chain means my foot is not on the floor, it's in the air. So if I try to bend my knee like this, it's also responsible for bending the knee. So it plays a part in that. Okay, so now some more anatomy about the knee. So remember, like we said, that the bones don't fit so nicely together. So we need a lot of structures to help stabilize the knee, to make sure we don't get in trouble, don't get into pain and things like that. So in the middle of the knee over here, there's these 2 purple ropes, 1 and 2. And those are the anterior cruciate ligament and the posterior cruciate ligament, also known as the ACL and PCL. If you guys have ever heard a sports report, there's always an athlete that tore their ACL or PCL, getting surgery to replace it. It's very, very common, with athletes at least. So these ligaments are responsible for making sure that the bones don't go forward and back. We don't want the bones to go forward and back. That is super painful. And say again?
What do you do for that?
They have to get surgery if they tear that, and they have to get months and months of.
How can I prevent that?
Well, on a everyday normal basis, just walking around, these don't usually get injured. It's usually from contact sports like football, baseball, basketball, things like that. So
Is it genetic a little bit? Do people sometimes, young people, I have a niece who seems to have the bone rubbing.
There
And she's
are
young.
certain people who, in general, have ligament laxity, which means that their ligaments are not as stable as they should be. It's sometimes a genetic thing. My ligaments in my body, in general, are usually lax. So it's something to watch out for. It's the type of thing where I might not want to get into contact sports if I know that about myself. So any type of, heavy sports like that, or even like what you mentioned, that someone rammed into you and came like on a rotational force, those things are dangerous and, definitely need to watch out for. Yep.
But if I walk now and I click, where does that come from?
Oh, we're going to talk about clicking.
Yeah.
That's coming up.
Now on my way here, I'll click.
We're going to talk about the clicking, yes. Very
That's
common. So other ligaments, so those ligaments are on the inside of the knee. On the outside of the knee, we have the medial collateral ligament and the lateral collateral ligament. So they run on the sides of the knee. A lot of my patients have pain on the sides of the knee. And the reason is because those ligaments are trying to stabilize you from the inside and the outside of the knee. And if for whatever reason there's misalignment, or if you're walking the wrong way, running the wrong way, standing the wrong way, you're putting pressure on things the wrong way, those ligaments are going to have a very hard time stabilizing you, and in the process, you're going to feel pain. So those are things to watch out for too. So now on the inside of the knee, so if you see this picture is from the front, but the one over there is actually showing it to you like it's opened. There's those two pink.
That's bad.
Yeah, we're going to talk about all that later on. I have a lot of slides on that. Yeah, we're going to talk about it.
For your knee.
So let's talk about the core of the knee. So the same way that you have an abdominal core that keeps you stable and keeps you feeling good, we need a core in the knee that keeps the knee stable and feeling good. So there are two muscles that make up the core of our knee. So the VMO, which is what we spoke about before. Remember that little muscle in the front on the bottom near the kneecap? And then there's this other muscle called the Popliteus, which is this muscle right back here. And it comes right in back of the knee, and basically it stabilizes the knee every time you open and close it. So if someone's having some sort of pain in their knee that's indicating to me that there's some instability, this is a muscle that I want to check out, because if this muscle is not turning on the right way, it can really lead to instability and pain in the knee. So
what muscle is that?
it's called the Popliteus. It's right in the back of the knee over here. It's teeny. It's not even something you could feel on yourself, but it's the type of thing that a PT or a doctor could definitely feel. Okay, so let's talk about some of the things that people say when they're having pain. So when someone says they have a feeling of locking, that a lot of times can indicate that there's a meniscal tear. So that's exactly how I felt. I literally felt like my leg was locked and I could not bend it. And that was a big indication to me that something was up with my meniscus. Feeling of popping. So I don't know if anyone's ever felt that, but it kind of feels like a bubble popping inside your knee. A lot of times it could be nothing, because in general in our joints in our body, there's air pockets, and sometimes if we're moving around, those air pockets, they pop, and so you might hear that popping noise. But sometimes if it's coming along with knee pain at the same time, it could indicate that maybe something is going on with the MCL or the ACL, which are those ligaments that we just reviewed. A feeling of giving way, so that a lot of times will be indicative of knee instability. So if you're walking or standing and you all of a sudden feel like it just gave way, or like it just buckled out of nowhere, a lot of times that can be an indication of knee instability. So back to that concept of the core, right? The quadriceps, the popliteus muscle, something must be up with one of those muscles that are responsible for the knee stability. Common causes of knee pain in age groups 50 years plus is osteoarthritis, gout. Are you guys familiar with gout?
Yes.
So
Pseudo-gout. Did you ever hear of pseudo?
I've not heard of that, no.
It's not uric acid, but
Oh.
it's supposed to be from too much calcium in the blood.
Interesting. Okay.
Yeah.
The gap was only in the big toe.
Yes, so most commonly found in the big toe, but it can actually appear in any joint in the body.
Yeah.
And it's really, really painful. And that's something that a lot of people 50 years and older can experience in any joints, but yes, most commonly in the big toe. And another source of pain is the Baker's cyst, which we'll talk about a little later. Okay, so locations of pain. So again, when someone comes in and says, oh, I'm having pain in the front of my knee, I'm having pain on the side of my knee, and back of my knee, there's different structures and different muscles that I need to think about that are in those areas that could be leading to the pain. So if it's in the front, it could indicate something going on with arthritis, maybe a meniscal tear, something going on with the kneecap. If it's on the side, medially, on the inside, it could indicate something with the MCL, which is the medial collateral ligament, or something with the medial meniscus. Laterally could be the LCL, the lateral meniscus, IT band, and posteriorly in the back, it could be a Baker's cyst, a gastroc muscle strain, hamstring strain, just any kind of muscle in that area that could be faulty or strained for whatever reason. So symptoms to watch out for. Any kind of burning pain can be an indication of gout, yeah?
So, not a gastroc muscle strain. I usually a tighter gastroc. What about perineal strain, where you're a weak outside ankles?
So, meaning what about that?
Like, how can what's the go-to exercise to help with that? Or how would I know that specifically my perineal also?
Well, first of all, if your gastrocs are tight in general, you should definitely be stretching those out.
Yeah.
It could also be that the peroneals are trying to overcompensate for the fact that your gastrocs are not flexible enough to do its job. But if you're having any peroneal tightness, you just want to, the peroneals are on the outside of your leg, right here. So you just do this to stretch them out. And if you want to strengthen them, you want to bring your foot out like this.
Oh, okay.
Kind of like you're drawing like a backwards jive with your toes.
Sounds good.
Yeah, that's a good exercise to do.
There's a little bit more.
Don't, I'm still counting, okay?
Oh,
Yeah.
go this one?
Is that in the packet?
Everything's in the packet.
Okay.
Yeah. All information's in the packet.
Okay.
So some symptoms to watch out for. So any type of burning or constant pain can indicate that there might be gout. Intermittent pain, so pain that's kind of on and off, comes and goes. If you notice it with only certain things like standing up or sitting down or when you're walking, that can be mechanical in nature. And you can always get an x-ray or an MRI through your doctor and see if something's going on. Anytime there's swollen or hot joint feelings, those are always not good signs. And that can be in any joint in your body. Anytime there's swelling, redness, if it feels hot to touch, that's something that you want to bring to the attention of your doctor for sure. Because that could be due to infection or arthritis, also gout. And again, knee pain can really be as a result of different things. So if someone's coming in for knee pain, it can also be as a result of hip pain or something that's going on in the hips that I need to check out that could be leading to pain in the knee. Or it could be something going on in the ankle, something that there's a misalignment or something that's not right. I need to check that out also and see if that might be causing the pain in the knee. So it's not always going to be a very clear-cut thing. And that's why we have the physical therapy exam. So basically, while I'm doing the exam, I'm checking for tons of things. I always want to go a joint above and a joint below. So if you're coming in for knee pain, we're going to look at your hip, your knee, and your ankle. We're going to look at range of motion. So I want to see how much mobility your knee has. There's standards of how much movement you should have, and if you're not reaching those standards, we need to figure out why. We need to look at the kneecap. It's very important to see how the kneecap is moving on the knee when you're bending it and when you're making it straight. So we really need to evaluate.
I can't find my kneecap.
Where?
Can't find it.
On both knees?
Yeah, they're both distorted.
So when I'm finished, I'm going to have to find that. Remind me before I leave. Other things that we do are strength testing. We want to see how strong the muscles are, like the quads, hamstrings, some of those muscles that we spoke about before. Stress testing. Stress testing just means that I'm putting stress on the different ligaments because I want to see if I'm going to get any pain or tenderness with that. because that can indicate that something's going on with it. And then special tests are just different tests based on different diagnoses that we are familiar with that we can do to see if something's present. Another big thing is that we look at the way that you walk. So that's called the gait analysis. And basically, watching the way you walk can tell us a lot about what's going on, because if we see that the way that you're walking is inefficient, or one of your techniques is faulty for how you're taking a step, or how you're putting your foot down, or how you're standing on your leg, that can be an indication to me that something's going wrong. And then I'll take a deeper look into that phase of walking and see how we can improve that and how we can make it better. And specifically with the quads and the hamstrings, those two muscles are so important for stabilizing the knee and the leg when you're walking. So definitely, if something's wrong with the way you walk, or if you're having pain when you walk, those are the two muscles that we really need to take a look at. Okay, so now we're going to talk about specific impairments. The first one is a Baker's cyst. It's basically a buildup of fluid right at the back of the knee, right over here. It's really painful, and a lot of times the doctors will do different things. Sometimes they will take the fluid out, but a lot of times they won't, because even when they take the fluid out, the fluid just comes right back, because they really need to figure out why there's a cyst there. A lot of times it could be due to arthritis, so the doctor will say, you know, go for physical therapy, see if you can strengthen, do some things to deal with the arthritis, and then maybe we'll see that the cyst will go down. More times than not, I've seen patients who have had it aspirated, they took the liquid out, and then it came right back. So what did you have done?
Nothing. I mean, as far as that goes. I mean, the doctor,
Yeah.
because I had a torn meniscus and the Baker's cyst, they didn't tell me I had a Baker's cyst. And I think my major pain was from that. I couldn't
Right.
bend. I was getting achy.
So
But
a lot of times the Baker's cyst happens after something else
yeah, I
happens. You probably tore the meniscus, and the Baker's cyst developed as a result. A lot of
or
times,
could have I had the Baker's, a torn meniscus, who knows, from way before,
Yeah.
and I did something to
for sure.
encourage a Baker's cyst.
Exactly.
Did you feel the cyst with your
Oh
finger?
yeah, for sure.
I didn't
See
feel
how it's
anything.
popping out?
Yeah.
Right
I
there,
didn't
it's
feel any
very
popping
palpable.
out.
So sometimes
But
you
I know
feel
from my
it.
MRI that I did have it. But they don't talk about that because they want to give you surgery. But I didn't
Yes.
do the surgery.
Right.
I went for a little therapy. I don't know how much it helped me or not, but she showed me some exercises for the Baker's cyst.
Okay.
So eventually, I still feel a little on the side of my, it's moved. What was
Right.
hurting me here moved to the other side. I don't know why.
Right.
A little bit.
Right.
And then most of the time I'm okay. I have a little bit of flare up, a little bit.
A little bit
Nothing
here
that I
and
can't
there.
walk
Okay.
or do.
Okay, good.
But I just want to ask you something. When you
yeah.
have surgery for your meniscus,
Yeah.
is that little? It depends on what they're going to do with you. They're going to take out your meniscus. They're going to. That's your cushion. Are they going to file it down, or are they just going to clean you
Right,
up?
so
or
it
what?
really, it's very much a case-by-case situation, but yes, a lot of times they do shave it down. A lot of times they really will recommend doing intense physical therapy before even considering a surgery, because there's really
Most
no
doctors won't. I
turning
went to
back
2
in surgery.
orthopedic doctors that said, "There's nothing you can do. You can't repair it. You need
Right.
surgery."
Right, it's unfortunate, because I feel like, you know, when you go and see a doctor and they tell you this is what you have to do, you're like, okay, I'm listening to the doctor, he said I need surgery, but a lot of times patients, you know, you need to be your own advocate. You need to tell the doctor, what else can I do?
Right.
There are patients that have been told by the doctor that they needed a knee replacement, came to me or to another therapist and said, you know, my doctor said I need a knee replacement. What do you think? Could we try to do therapy for like 2 months? Maybe I'll get better, maybe I won't need it. Sometimes it's helpful, sometimes.
To go that
so
far.
Arthritis.
Oh, the
And we're going
arthritis?
to talk about that.
I
Yeah.
thought when you have arthritis, they don't like to work on you.
Who, the doctors or the
Yeah.
therapists?
The doctors.
Oh yeah, so we're going to talk about that. I know,
Yeah.
it's very annoying.
They don't
What's
really have
your
a lot of
opinion on
vibrate.
taking glucose?
They're afraid to touch you.
Is that helpful to build the cushionings between?
That's what I need.
So for some people it works.
This surgery, yeah.
Right, so sometimes it works for some people, sometimes it doesn't help at all. So it's the type of thing that, again, you would need to consult your doctor, see what they think. But again, with arthritis especially, like there's literally, I can't say that there's one thing that I can think of that patients have told me helped them. That was like a breakthrough, like they couldn't believe it. It's always trial and error, trying something, seeing if it works, didn't work, try the next thing. So it's like a constant back and forth. So the next one is arthritis. So I'm sure at some point or another, everyone's been told that they have arthritis for something. Everyone comes in and says, I have arthritis here, in my back, in my knee, in my hand.
And you could tell from an x-ray?
Yes, so the doctor will be able to tell you from an x-ray and also from an MRI. They could get details from both. So it's very frustrating because, like we said, patients will go on different medications, injections, will try all these different things. And I can't say that they help or they don't help because every patient's different and it's very much on, on an individual basis, but physical therapy really can help with arthritis.
I think they say the cortisone injections for the knee in particular, are not good.
So in general, cortisone injections are, I'm not a fan of them, only because there's so many side effects. But again, I'm not a medical doctor, so I can't make that decision.
I don't mean those kind of, I mean in particular to the knee. Because even when I went for therapy, she says, well, maybe you could have one, but don't have more than that.
It's really not recommended, the truth is, even like 2 maximum. But again, just remember those shots are like a Band-Aid. It's just masking your pain until you got the next incident of pain. So it's the injections, that's why it's important to really figure out what's going on and what's wrong. Because even if you could do exercise to try and help the pain, you could avoid getting all those injections, So with arthritis, a lot of times you'll feel buckling, blocking, giving way, pain going up and down the stairs, pain while you're sitting.
4 times, maximum the whole time.
So how can we treat it? So again, like I said, it really depends on the patient's history and what their medical background is. But doing strengthening exercises for your knee can really, really be so helpful. And especially with focus on the quadriceps. We're going to practice some quad exercises at the end of the session. But in general, really focusing on strengthening the quads can be very helpful for arthritis. Other exercises to focus on is just endurance in general, improving balance, coordination, just strengthening in general with a focus on the leg could be very, very helpful. There's also another syndrome called patellofemoral pain syndrome, which is basically just pain by the front of the knee. And it's also a type of arthritis basically that happens between the kneecap and the femur. So the way that it glides on the bone is not so smooth anymore. So a lot of these patients will feel pain when they're sitting for a very long time, going up and down the stairs, squatting, like bending down to pick something up off the floor. And again, I can't stress it enough. The treatment for them is just a lot of quad strengthening. Even trying to work on their ligaments, trying to do like massage on their ligaments just to increase stability of them. All those things are very helpful. Taping is also another treatment method that's used especially with the patellofemoral pain syndrome. I actually got certified in taping this summer, and taping is really a terrific way to treat tons of things. I put tape on a lot of patients for a lot of different reasons. It helps with strengthening, it helps with stability, it helps with pain, it helps with swelling, almost anything you could think of. There's different ways of applying the tape, which is what I learned in my course. And the way that you apply it and the way that you put it on, the way that it sits on the skin can really help, especially with this syndrome. So in the picture, they put it around the kneecap just to relieve some of the pain and pressure that they have. For some patients, it works wonders, and they come back every session and they're like, put more tape. Some people don't feel such a big difference.
They call me all the time if I want braces.
Braces?
Braces for my knee or my
Oh, they
back.
give you a brace
Oh, a
sometimes.
brace, depending on if you need it, yeah.
I told them, what shall I do with that? I mean, something like this?
It could be, it has to be evaluated.
They called me, they said, if you have knee pain, we have braces for you, or back pain, we have braces.
Right, so sometimes they'll put like a strap or like a little like brace with like an ace. You could always try it and see if it helps.
But who can pay for that?
I just don't want it to be so
Sometimes they
full.
sell it in the pharmacy. Sometimes they give it to you through your insurance.
Today,
Just for the moment, but
kind of,
forever. It comes back if I don't wear this.
Listen, it's all trial and error. You can try and see.
It just, I think this
Right, yes, and a lot of people feel good when they put that on. So again, it depends on what's going on. But again, these are the types of things that you would want to consult your doctor or your therapist on before just trying it out on your own.
And I feel bad because certain things I can't put glasses that.
Okay, so we're going to talk about different exercises. And again, you know, if you're really having pain and it's something that you haven't checked out, I would obviously recommend that you go to a doctor or a physical therapist to check it out first. But, you know, if these are the types of things, like you know that you had a Baker's cyst one time, you could definitely follow some of these exercises at home because any one of these exercises will definitely help with stability of your knee. So there's different phases of exercise. Phase 1 is the type of exercises you would do when it's, you know, you're still having a lot of pain, you're still early in the stage of acute inflammation. Stage 2 is when you're feeling a little bit better, you want to increase the amount of strengthening. And then phase 3 is more intense exercise. So I just gave some examples of each phase. So what I did is that I explained how to do the exercise in the first slide, and in the second one I put a picture. So we're just going to go according to the pictures, and I'll explain it to you guys, but all the instructions are in the booklets. So these are quad sets, and they're extremely easy to do. Basically, you just lie down. It could be on the floor, if you're comfortable doing it on the floor, or on your bed, and you put something under your knee, like a pillow, or maybe like a light towel or something. And then all you do is squeeze down, and you hold it for 10 seconds. That's called an isometric contraction, which just means that you're activating the muscle without actually moving it, and that's a really good form of a stability exercise. You're going to be doing lots of those after your surgery.
My doctor said it's not allowed to put anything under the knee.
When? After the surgery?
After the surgery.
So once you get physical therapy after your surgery, you'll see that your therapist is going to help you do these. These are really important. So I'm just going to demonstrate how to do it. So if I was lying down or sitting down on my bed or on the floor, you could really just put it underneath. And then you're just thinking about squeezing down. Like I want to just squeeze down. And then you feel this front part of your muscle getting really tight and hard. So you want to hold it for 10 seconds, and then you can let it go. And then you're going to press down. And once you're comfortable doing this, then you can practice lifting the leg, going into a straight leg raise, holding that for 15 seconds, and then coming down. That is really hard to do. It looks easy, but it's not. So you want to make sure that you master this first, and then once you're comfortable enough doing this, then you can go into thinking about lifting your leg.
Why is it so crucial to master the first one first? Because I have done raising my leg and I've never done the first part.
So when you think about activating this first, that's going to stabilize your knee. That's going to give you stability in the upper portion of your leg. So just telling you to lift your leg, like if I just lift my leg like this is definitely turning on. But if I think about activating this first and then lifting my leg, I'm getting a much better exercise.
Okay.
Yeah.
When I sit like this, how is that working with what you're saying? If I'm sitting,
What do you mean? How is it
well,
working?
you're safe lying down. A lot of times I do this.
So you're still activating your quads when you do that. That's perfectly fine. So I'm just doing it in a lying down position because this is more of like a phase 1 exercise where we're thinking of maybe we have some pain like, what's your name, sorry? Lulu. So when she's done with her surgery, she's going to be in a lot of pain. She can't do something like sitting on a chair and lifting the leg up. So this is the type of thing where after surgery or after having a lot of pain with maybe a trauma or something, you would want to do it, you know, lying down or something.
Okay, but if you don't have any pain,
Yeah.
it's okay to sit instead of lying down?
Perfectly fine. Okay, so those are quad sets, super important. Another exercise is knee flexion. So that's really simply what it shows on the picture. You're lying down and you're bending the knee towards your chest, and then you're letting it go back out. And the same thing can go for this. If you wanted to do it in a chair, you could just swing your leg back and then come forward, just like that. You could even do it against the wall. You could bend your knee up and then come back down. There's so many ways to do this, really. Okay, so example of a phase 2 exercise. So this is called a short arc quad set. It's similar to the quad set that I just did, but it's a little bit different, and I'll show you how. So this is the same concept, but you're going to use something a little bit thicker, like you're going to roll up like maybe a pillow or like a very thick towel, because you really want to get your knee into a flexed position. And then from this position, you're going to make your leg straight, hold it for 10 seconds, and then come back down. Yeah. And when I want to progress this exercise with my patients, I'll even put some ankle weights on their ankles, because that will make it even harder. It's the same idea like doing it in the chair. Doing it in the chair is probably even harder because your knee has to overcome all that range to get up. Okay, another phase 2 exercise is a wall slide or a squat. So you're just gonna
Muscles are you working when you do that?
the quads.
The quads.
And this
All
is
of
good
these-
for anything mostly.
Anything,
You just
but I really
strengthen.
want you to watch the way I do it. Your feet need to be shoulder width apart. Your back needs to be straight. And then when you go down, you really have to make sure that your knees are not coming in or going too far out. You want to make sure that your knees are really centered and you're coming down and then coming right back up. Let's say I went this far down and I had pain. No good. You should not have pain with this. So if that was too painful, go a little bit less than that.
Just go as far as you
Go as far as you can without having pain. I would also recommend doing this in front of a mirror or in front of someone that's watching you that could give you feedback just to make sure that you're that you're straight the whole time, because you don't want to put unnecessary pressure on the kneecaps when you're doing that. Okay, and the last one, these are called step up and downs. And this, well, we're just going to use this for an example, but you could use like a step in your house, like by your staircase, or you could use a heavy textbook, or like if you have a very sturdy box. And then with the leg that you want to strengthen, like let's say I have a lot of pain in my right knee. So I'm going to put my right leg up, and then I'm going to bring my left leg, and I'm going to tap, and then I'm going to come down. I'm going to tap, and I'm going to come down, because just the act of going up and down, my quads need to be firing the whole time that I do that. And obviously the higher up that step is, the more work your leg has to do. So that's a really good one.
Could you do it on a regular step, or is that too hard?
Like a step by your staircase?
A step, when I went for therapy, they had, you know, those steps there, and
Yeah,
they made me do
we have that
something
also, and we
similar.
have different heights.
Yeah.
So depending on how much a patient can handle, I might do, you know, one that's a little bit higher for more of a challenge, one that's a little bit lower if they're in a lot of pain. You could do the same concept with a side step also. So you're coming down from the side and then coming up. So you could do a front, back, and side.
When I go down the steps, I have to go like a child. you
Like
know,
one by one?
One by one,
Yeah.
and sideways.
Mm-hmm.
And because I have pain in my knee, what do you think of that?
So again, this is the type of thing that really needs to be evaluated, because again, there's so many things that are going on with the knee. Just like based on what we saw today, we saw so many ligaments, so many muscles that really all needs to be evaluated to see exactly where that's coming from. But again, you could try these exercises, let's say for like the next 2 weeks, see if it helps. It might just be that you need to strengthen your quads just to give yourself a little bit more stability. If you try those exercises and they weren't helpful, I would say to maybe see a doctor or a physical therapist.
It's just one knee, one.
Yeah. Try the exercises and see how it works out. Yep.
Do I remember they put me, I have a bicycle at home, a stationary. Is that supposed to be good for the knees?
Okay, so that's questionable because again, it depends on what's going on. So let's say with you, you had the meniscus tear, the biggest cyst. I'm not sure that I want to put pressure because when you're using a bike, you know, you're bending your knee to such a degree that your kneecap is really having to go up and down and over your knee repetitively. I don't know if that's something that I would want you to do. So again, that's a question that you would have to ask the doctor or therapist that's working with you.
Well, they put me on it, but that doesn't mean they, you know, maybe that was just protocol, you
Right.
know.
How did you feel afterwards?
I don't know if anything helped me so much, but I did. I even did that exercise where I lay down and I had to take a string and pull my leg all the way up till
So
it
that's
practically
a stretch,
hurt.
right? That's
That was a
type of
stretch, but that was a big stretch.
right. So
And hold it
sometimes-
for 10 seconds or 25 seconds, I don't remember maybe 10 seconds.
Right, so again, doing a stretch really relates back to the idea of is your muscle functioning the way that it should be. Just like that guy asked me before, something about how he had a tight muscle. Sometimes when you have tightness, it could be leading to other things happening like decreased range of motion, and that tightness can cause issues with walking that might lead to pain. There's so many different things. So again, getting the evaluation will really help, you know, isolate what could be like the 1 or 2 major factors that are causing the pain. And then from that, we come up with a treatment plan based on what we see. So if they put you on a stretch, it could be that one of your muscles may have been tight, that may have been causing some of that pain.
Could have been, or it's protocol that they give you a certain
knows,
amount of
right?
exercise.
It's true.
I don't think it was so analyzed, so even though I brought in my MRI and the paper and whatever,
Right.
I don't know if it was looked at,
Sometimes it's just
so,
protocol.
yeah.
Yeah. All right, so is there anything else that I could help you guys with? Any questions? Yep.
So a lot of times I do the home assessments with a lot of our seniors, and what she brought up is what we see a lot, people going down the stairs sideways. And for numerous reasons, that's dangerous, just because you're putting, you know, your first source of contact is your outside tendon as it hits the stairs. So when I see that, and it could be any weight. It's not people are heavier or had nothing to do with that. So should that always be an instance where you say, you know, that's a fall risk, going down sideways like that? You should be able, because you're putting too much pressure on one particular joint as you're going.
So obviously this is not the natural way of doing things, so it could potentially be a fall risk, but even just going up and down the stairs the natural way could be a fall risk. Really, there's so many different things that can make something a fall risk, but that definitely is not the ideal way to go up and down the stairs, and I think that you need to figure out why they were doing that. And if they tell you, oh, it's because I have too much pain in my knee, that's something that they need to figure out, especially like if they're having so much pain to the point where they have to change the way they're going up and down the stairs. That's like a red flag, because like, you know, if you're changing your whole technique of doing something, it's kind of a big problem. And a lot of people will be like, oh, it's no big deal, oh, I have pain, whatever. But why not figure it out? Especially guys with physical therapy, it's so easy. All you need to do is go to your doctor and say, hey, can I see a physical therapist? They give you a prescription, physical therapy for 12 weeks, and you go anywhere you want, see whatever physical therapist you want. It's not like a whole...
So that's the problem, because some people don't. Some people's insurance, you can't get it unless you've been in a hospital.
Right.
And you're being discharged, or you had surgery. You know, once you're on Medicare,
Right,
it's
and
a little bit
especially if
easier.
they're getting therapy at home, they can't also be getting therapy in an office.
Right.
And most of the time, I don't want to speak for everyone, home care therapy is not that great. So, not the best.
It's good to get you to the point where you can get outside and get in a car to go to an
that
office,
act itself
but
is really important.
When you walk, which muscles are you using? Which group of muscles?
So, you're using a lot of muscles, but the ones that we highlighted today are the hamstrings in the back and the quads in the front.
Right.
Those are two really important muscles that you use while you're walking, standing, going up and down the stairs. That's why they're so big also, right? It's like a very big muscle because it really needs to do a lot of work.
And what about riding a bicycle?
Also using those muscles, yeah?
You can't.
Yep.
She's saying, and you
Yes.